We'd like to welcome you to the RNSG 1424 Exam 2 Cumulative Lecture. We will be discussing the concepts of fluid and electrolyte balance, clotting, teamwork and collaboration, perfusion, leadership and management. With the concept of fluid and electrolyte balance, the definition is the process of regulating the extracellular fluid volume, body fluid osmolality, and plasma concentration of electrolytes. The exemplars to be discussed are dehydration with the elderly, extracellular fluid volume excess, hypokalemia, hyperkalemia, chronic renal failure, hyponatremia, syndrome of inappropriate antidiuretic hormone, hypernatremia, diabetes insipidus, hypo and hyperphosphatemia, hypo and hypermagnesemia, and hypercalcemia. In the beginning of understanding the concept fluid and electrolyte balance and the exemplars, it would be a benefit to review your definitions in the Hinkle book on page 237. Active transport is physiologic pump that moves fluid from an area of lower concentration to one of higher concentration. Active transport requires adenosine triphosphate for energy. With diffusion, that is the process by which solutes move from an area of higher concentration to one of lower concentration, and this does not require expenditure of energy. There is also hydrostatic pressure, the pressure created by the weight of fluid against the wall that contains it. In the body, hydrostatic pressure in blood vessels results from the weight of fluid itself and the force resulting from cardiac contraction. Hypertonic solutions, a solution with an osmolality higher than that of serum. Hypotonic solution is a solution with an osmolality lower than that of serum. Isotonic solutions are a solution with the same osmolality as a serum of other body fluids. Osmosis is the process by which fluid moves across a semi-permeable membrane from an area of low solute concentration to an area of high solute concentration. The process continues until the solute concentrations are equal on both sides of the membrane. With dehydration, especially in the elderly, there are normal physiologic changes of aging, including reduced cardiac, renal, and respiratory function and reserve, and alterations of the ratio of body fluids to muscle mass. These may alter the responses of older people to fluid and electrolyte changes. Renal function declines with age, as do muscle mass and daily exogenous creatinine production. Therefore, high normal and minimally elevated serum creatinine values may indicate substantially reduced renal function in older adults. Because of a decrease in age-related muscle mass, older people have a lower concentration of body fluid that may alter physiologic responses. Routine procedures such as the vigorous administration of laxatives or enemas before colon X-ray studies may produce a serious fluid volume deficit, necessitating the use of intravenous fluids to prevent hypotension and other effects of hypovolemia. In many older patients, the clinical manifestations of fluid and electrolyte disturbances may be subtle or atypical. For example, fluid deficit may cause delirium in the older person. Rapid infusion of an excessive volume of IV fluids may produce fluid overload and cardiac failure in older patients. Dehydration in older adults is common because of their decreased kidney mass, decreased glomerular filtration rate, decreased renal blood flow, decreased ability to concentrate urine, inability to conserve sodium, decreased excretion of potassium, and a decrease of total body water, loss of subcutaneous supporting tissue, and resultant thinning of the skin occurs with aging. The dermis is dehydrated and loses strength and elasticity. These skin changes affect placement of peripheral IV catheters in older adults. With hypovolemia or fluid volume deficit, these occur when losses of extracellular fluid volume exceeds the intake of fluid. It occurs when water and electrolytes are lost in the same proportion as they exist in normal body fluids. Thus, the ratio of serum electrolytes and water remains the same. Fluid volume deficit should not be confused with dehydration, which refers to loss of water alone with increased serum sodium levels. Fluid volume deficit may occur alone or in combination with other imbalances. These imbalances, which are serum electrolyte changes, may also exist. Potassium and sodium levels can be reduced. Hypokalemia occurs with GI and renal losses. Hyperkalemia occurs with adrenal insufficiency. Hyponatremia occurs with increased thirst and ADH release. Hypernatremia results from increased insensible losses and diabetes insipidus. For the medical management of fluid volume deficit, isotonic electrolyte solutions like lactated ringers or 0.9% sodium chloride are frequently the first-line choice to treat hypotensive patients with the fluid volume deficit because they extend plasma volume. The normal body for homeostasis would be the renin-angiotensin-aldosterone system. As the sympathetic nervous system is stimulated, aldosterone is released in response to an increased release of renin, which decreases urine production. For nursing management, we must assess and monitor and measure fluid I&O at least every 8 hours and sometimes hourly. We must also assess body fluid losses because they may exceed fluid intake through excessive urination, polyuria, diarrhea, vomiting, or other mechanisms. Vital signs are closely monitored, observing for a weak rapid pulse and orthostatic hypotension. Remember, orthostatic hypotension is decreased in systolic pressure exceeding 20 millimeters of mercury when the patient moves from a lying to a sitting position. Skin and tongue turgor are monitored on a regular basis. An older person, you have to remember their skin is very frail. With fluid volume deficit, the skin flattens more slowly after the pinch is released. In a person with severe fluid volume deficit, the skin may remain elevated for many seconds. Measure the turgor by pinching the skin over the sternum, inner aspects of the thighs, or forehead. In extracellular fluid volume excess, the fluid volume excess refers to an isotonic expansion of the extracellular fluid caused by the abnormal retention of water and sodium in approximately the same proportions in which they normally exist in the extracellular fluid. It is most often secondary to an increase in the total body sodium content, which in turn leads to an increase in total body water. Because there is isotonic retention of body substances, the serum sodium concentration remains essentially normal. Within the pathophysiology, the fluid volume excess may be related to simple fluid overload or diminished function of the homeostatic mechanisms responsible for regulating fluid balance. Contributing factors can include heart failure, renal failure, and cirrhosis of the liver. Another contributing factor is consumption of excessive amounts of table or other sodium salts. Clinical manifestations would result from expansion of the extracellular fluid and may include edema, distended neck veins, and crackles, which would be abnormal lung sounds. The medical management is directed at the causes, and if related to excessive administration of sodium-containing fluids, discontinue the infusion may be all that is needed. Symptomatic treatment consists of administering diuretics and restricting fluids and sodium. Nursing management for extracellular fluid volume excess would include the nurse measuring I&O at regular intervals to identify excessive fluid retention. The patient is weighed daily and rapid weight gain is noted. Breath sounds are assessed at regular intervals at risk patients, particularly if parenteral fluids are being administered. The nurse also monitors the degree of edema in the most dependent parts of the body, such as the feet and ankles in ambulatory patients, and in the sacral region in patients confined to bed. Pitting edema can be assessed by pressing a finger into the affected part, creating a pit or indentation that is evaluated on a scale of 1+, which is minimal, to 4+, which is severe. Also wanting to prevent hypervolemia is essential for the nursing management. Most patients require sodium-restricted diets in some form, and adherence to the prescribed diet is encouraged. Patients are instructed to avoid over-the-counter medications without first checking with a healthcare provider, because these substances may contain sodium. Regular rest periods may be beneficial for the patient because bed rest favors diuresis of fluid. If dyspnea or orthopnea is present, the patient is placed in a semi-Fowler's position to promote lung expansion. The patient is turned and repositioned at regular intervals because edematous tissue is more prone to skin breakdown than normal tissue. In the exemplar hypokalemia, the serum potassium is less than 3.5 milliequivalents a liter. The contributing factors would be diarrhea, vomiting, gastric suctioning, corticosteroid administration, carbenicillin, amphotericin B, which are medications, bulimia, osmotic diuresis, alkalosis, starvation, diuretics, and digoxin toxicity. The clinical manifestations would be fatigue, anorexia, nausea and vomiting, muscle weakness, polyuria, decreased bowel motility, ventricular asystole or fibrillation, paresthesias, leg cramps, decreased blood pressure, ileus, abdominal distension, hypoactive reflexes. When looking at an ECG, you'll have flattened T waves, prominent U waves, ST depression, and prolonged PR interval. It's helpful to you if you review Table 13.4, page 246, for these contributing factors and for these manifestations. For patients who are at risk for hypokalemia, a diet containing sufficient potassium should be provided. Foods high in potassium include most fruits and vegetables, legumes, whole grains, milk, and meat. When dietary intake is inadequate for any reason, oral or IV potassium supplements may be prescribed. Within the nursing management, hypokalemia can be life-threatening. The nurse needs to monitor for its early presence in patients at risk. To prevent hypokalemia, careful monitoring of fluid, I&O, is necessary because 40 milliequivalents of potassium is lost for every liter of urine output. The ECG is monitored for changes, and arterial blood gas values are checked for elevated bicarbonate and pH levels. To correct hypokalemia, the oral route is ideal to treat mild to moderate hypokalemia because oral potassium supplements are absorbed well. Oral potassium supplements can produce small bowel lesions, therefore the patient must be assessed for and cautioned about abdominal distension, pain, or GI bleeding. Administration of IV potassium is done with extreme caution using an infusion pump with the patient monitored by continuous EKG. In hyperkalemia, the serum potassium is greater than 5 milliequivalents per liter. There are contributing factors: oliguric renal failure, use of potassium-conserving diuretics in patients with renal insufficiency, metabolic acidosis, Addison's disease, crush injuries, burns, stored bank blood transfusions, rapid IV administration of potassium, and medications such as ACE inhibitors, NSAIDs, and cyclosporines. The manifestations will show as muscle weakness, tachycardia that will turn to bradycardia, dysrhythmias, flaccid paralysis, paresthesias, intestinal colic, cramps, abdominal distension, irritability, anxiety, and ECG changes. When hyperkalemia develops, medical management includes an ECG to obtain immediately to detect any changes. Pharmacological measures would be to administer IV calcium gluconate. Within minutes after administration, calcium antagonizes the action of hyperkalemia on the heart, but does not reduce the serum potassium concentration. Monitoring the blood pressure is essential to detect hypotension, which may result from the rapid IV administration of calcium gluconate. The ECG should be continuously monitored during administration. The appearance of bradycardia is an indication to stop the infusion. Nursing management will include monitoring the I&O and observing for signs of muscle weakness and dysrhythmias. When measuring vital signs, an apical pulse should be taken. The presence of paresthesias and GI symptoms such as nausea and intestinal colic are noted. Serum potassium levels as well as BUN, creatinine, glucose, and arterial blood gas values are monitored for patients at risk for developing hyperkalemia. To help prevent hyperkalemia, patients should adhere to the prescribed potassium restriction. Potassium-rich foods should be avoided. And also, labels of cola beverages must be checked carefully because some are high in potassium and some are not. In the exemplar hyponatremia, it primarily occurs due to an imbalance of water rather than sodium. In addition, some medications such as anticonvulsants, sertraline, Paxil, or desmopressin acetate increases the risk of hyponatremia. Syndrome of inappropriate antidiuretic hormone is seen in hyponatremia. It can be the result of either sustained secretion of antidiuretic hormone by the hypothalamus or production of an antidiuretic hormone-like substance from a tumor. Clinical manifestations include poor skin turgor, dry mucosa, headache, decreased saliva production, orthostatic fall in blood pressure, nausea, vomiting, and abdominal cramping. Neurologic changes occur such as status epilepticus, altered mental status, and coma. Features of hyponatremia associated with sodium loss and water gain include anorexia, muscle cramps, and a feeling of exhaustion. Medical management includes treat the underlying cause. The most common treatment for hyponatremia is careful administration of sodium by mouth, nasogastric tube, or parenteral route. For patients who can eat and drink, sodium is easily replaced because sodium is consumed abundantly in a normal diet. For those who cannot consume sodium, lactated Ringer solution or isotonic saline may be prescribed. Patients with normal or excess fluid volume, hyponatremia is usually treated effectively by restricting fluids. Pharmacological therapy can be utilized also. IV Vaporsol use is limited to the treatment of hospitalized patients. Samska is an oral medication indicated for clinically significant hypervolemic and euvolemic hyponatremia that must be initiated and monitored in the hospital setting. The nursing management includes monitoring INO as well as daily body weight. It is also necessary to monitor their lab values, the sodium of course, and be alert for those GI manifestations such as anorexia, nausea, vomiting, and the abdominal cramping. The nurse must also watch those central nervous system changes such as the lethargy, confusion, muscle twitching, and seizures. Neurologic signs are associated with very low sodium levels that have fallen rapidly because of fluid overloading. The nurse encourages foods and fluids with high sodium content to control hyponatremia. Broth made with 1 beef cube contains approximately 900 milligrams of sodium. 8 ounces of tomato juice contains approximately 700 milligrams of sodium. In the exemplar hypernatremia, it is a serum sodium level higher than 145 milliequivalents a liter. It can be caused by a gain of sodium in excess of water or by a loss of water in excess of sodium. In sodium excess, the patient ingests or retains more sodium than water. Less common causes of hypernatremia are heat stroke or near drowning in seawater, malfunction of hemodialysis or peritoneal dialysis systems. Also, IV administration of hypertonic saline or excessive use of sodium bicarbonate can cause hypernatremia. Exertional dysnatremia can occur in marathon runners and can result in life-threatening encephalopathy. Hypernatremia and exercise-associated hyponatremia may manifest similarly with confusion and disorientation. Some clinical manifestations is the primary characteristic is thirst. Thirst is such a strong defender of serum sodium levels in healthy people that hypernatremia never occurs unless the person is unconscious or does not have access to water. However, those who are ill and older adults may have an impaired thirst mechanism. For the medical management treatment of hypernatremia, it consists of gradual lowering of the serum sodium level by the infusion of a hypotonic electrolyte solution, like 0.3 sodium chloride, or an isotonic non-saline solution, like dextrose 5% in water, which is also called D5W. In the nursing management, the nurse should assess for abnormal losses of water or low water intake, and for large gains of sodium, as might occur with ingestion of over-the-counter medications that have a high sodium content, like Alka-Seltzer. In addition, the nurse obtains a medical history because some prescription medications have a high sodium content. The nurse also notes the patient's thirst or elevated body temperature and evaluates it in relation to other clinical signs and symptoms. Their behavior is also monitored, such as restlessness, disorientation, and lethargy. For patients with diabetes insipidus, adequate water intake must be ensured. If the patient is alert and has an intact thirst mechanism, merely providing access to water may be sufficient. If the patient has a decreased level of consciousness or other disability interfering with adequate fluid intake, parenteral fluid replacement may be prescribed. To correct the hypernatremia, parenteral fluids are necessary for managing the hypernatremia. The nurse monitors the patient's response to the fluids by reviewing serial serum sodium levels and by observing for changes in neurologic signs. In the exemplar hypophosphatemia, that is the serum level below 2.5 milligrams per deciliter. Hypophosphatemia may occur during the administration of calories to patients with severe protein-calorie malnutrition. This syndrome can be induced in any person with severe protein-calorie malnutrition, like patients with anorexia nervosa or alcoholism, or even older debilitated patients who are unable to eat. Marked hypophosphatemia may develop in malnourished patients who receive parenteral nutrition if the phosphorus loss is not corrected. Other causes of hypophosphatemia include heat stroke, prolonged intense hyperventilation, alcohol withdrawal, poor dietary intake, diabetic ketoacidosis, respiratory alkalosis, hepatic encephalopathy, and major thermal burns. Symptoms or clinical manifestations of hypophosphatemia include paresthesias, muscle weakness, bone pain, chest pain, respiratory failure, seizures, and tissue hypoxia. Hypoxia leads to an increase in respiratory rate and respiratory alkalosis, causing phosphorus to move into the cells and potentiating hypophosphatemia. Muscle damage may develop as the ATP level in the muscle tissue declines. Clinical manifestations are muscle weakness, which may be subtle or profound and may affect any muscle group. Muscle pain and at times acute rhabdomyolysis, which is the breakdown of skeletal muscle. Weakness of respiratory muscles may greatly impair ventilation. The medical management mostly is trying to prevent hypophosphatemia, but if a patient does have hypophosphatemia, medical management includes adequate amounts of phosphorus adding to parenteral solutions and attention paid to the phosphorus levels in enteral feeding solutions. In nursing management, the nurse identifies patients at risk for hypophosphatemia and monitors them. Malnourished patients receiving parenteral nutrition are at risk when calories are introduced too aggressively. Preventative measures involving gradually introducing a solution to avoid rapid shifts of phosphorus into cells must be utilized. For patients with documented hypophosphatemia, careful attention is given to preventing infection because hypophosphatemia may alter the granulocytes. Nurses must report early signs of hospophosphatemia, which is apprehension, confusion, and a change in level of consciousness. If the patient experiences mild hypophosphatemia, foods such as milk and milk products, organ meats, nuts, fish, poultry, and whole grains should be encouraged. The exemplar hypophosphatemia is a serum phosphorus level that exceeds 4.5 milligrams per deciliter. The most common cause of hyperphosphatemia is renal failure. Other causes include increased intake, decreased output, or shift from the intracellular to extracellular space, conditions such as excessive vitamin D intake, administration of total parenteral nutrition, chemotherapy for neoplastic disease, hypoparathyroidism, metabolic or respiratory acidosis, diabetic ketoacidosis, acute hemolysis, high phosphate intake, profound muscle necrosis, and increased phosphorus absorption. The clinical manifestations, most common symptoms result from decreased calcium levels and soft tissue calcifications. The most important short-term consequence is tetany. Tachycardia, anorexia, nausea and vomiting, and muscle weakness, including signs and symptoms of hypocalcemia, hyperactive reflexes, and those soft tissue calcifications in the lungs, heart, kidneys, and cornea are the clinical manifestations. Medical management is treated at directing the underlying disorder. For example, hyperphosphatemia may relate to volume depletion or respiratory or metabolic acidosis. Nursing management includes having a low phosphorus diet. So those are avoiding phosphorus-rich foods such as hard cheeses, cream, nuts, meats, whole grain cereals, dried fruits, dried vegetables, and kidneys, sardines, sweetbreads, and foods made with milk. We also instruct the patient to avoid phosphate-containing laxatives and enemas. We educate the patient about recognizing the signs of impending hypocalcemia and monitoring for changes in urine output. Hypomagnesemia is a serum magnesium level less than 1.8 milligrams per deciliter. Magnesium is similar to calcium in two aspects. First, it is the ionized fraction of magnesium that is primarily involved in neuromuscular activity and other physiologic processes. And second, magnesium levels should be evaluated in combination with albumin levels. Because about 30% of magnesium is protein-bound, principally to albumin, a decreased serum albumin level can reduce the measured total magnesium concentration. For contributing factors in pathophysiology, an important route of magnesium loss is the GI tract. Such loss can occur with nasogastric suctioning, diarrhea, or fistulas. Because fluid from the lower GI tract has a higher concentration of magnesium than fluid from the upper tract, losses from diarrhea and intestinal fistulas are more likely to induce magnesium deficit than those from gastric suctioning. It also may occur with withdrawal from alcohol and administration of tube feedings or parenteral nutrition. Chronic alcohol abuse is a major cause of symptomatic hypomagnesemia. If the enteral or parenteral feeding formula is deficit in magnesium content, serious hypomagnesemia will occur. Because of this, serum magnesium levels should be measured at regular intervals in patients who are receiving parenteral or enteral feedings, especially those who have undergone a period of starvation. Magnesium deficiency often occurs in diabetic ketoacidosis, secondary to increased renal excretion during osmotic diuresis and shifting of magnesium into the cells with insulin therapy. Other causes include administration of certain medications and citrated blood. Clinical manifestations of hypomagnesemia are due directly to the low serum magnesium level. Others are due to secondary changes in potassium and calcium metabolism. Chvostek's and Trousseau signs occur in part because of accompanying hypocalcemia. Hypomagnesemia may be accompanied by marked alterations in psychologic status. Apathy, depressed mood, apprehension, and extreme agitation may be noted, as well as ataxia, dizziness, insomnia, and confusion. At times, delirium, auditory or visual hallucinations, and frank psychosis may occur. Magnesium deficiency can disturb the ECG by prolonging the QRS, depressing the ST segment, and predisposing to cardiac dysrhythmias. Medical management for mild magnesium deficiency can be corrected by diet alone. Principal dietary sources of magnesium include green leafy vegetables, nuts, seeds, legumes, whole grains, seafood, peanut butter, and cocoa. If necessary, magnesium salts can be administered orally in an oxide or gluconate form to replace continuous losses, but can produce diarrhea. Patients receiving parenteral nutrition require magnesium in the IV solution to prevent hypomagnesemia. For nursing management, observation is essential. Nurses must observe for signs and symptoms. If hypomagnesemia is severe, seizure precautions are implemented, and other safety precautions are instituted if confusion is observed. Patient education plays a major role in treating magnesium deficit. The patient is educated about the sources of magnesium-rich foods. In the exemplar hypermagnesemia, that is serum magnesium levels greater than 2.3 milligrams per deciliter. The pathophysiology include renal failures, the most common. The oliguric phase of renal failure, particularly when magnesium-containing medications are administered, and also adrenal insufficiency. Untreated diabetic ketoacidosis is also a cause. Adrenal insufficiency and excessive IV magnesium administration is an issue. Hypothyroidism is also a cause. Clinical manifestations include flushing, hypotension, muscle weakness, drowsiness, hypoactive reflexes, depressed respirations, cardiac arrest, coma, diaphoresis, and ECG changes. An acute elevation of the serum magnesium level depresses the central nervous system and the peripheral neuromuscular junction. The respiratory center is depressed. Atrioventricular heart block and cardiac arrest can occur when that magnesium level is greatly elevated and not treated. These high levels of magnesium can also result in platelet clumping and delayed thrombin formation. For the management of hypermagnesemia, nursing management will include monitoring the vital signs, noting hypotension and shallow respirations. The nurse will also observe for deep tendon reflexes that are decreased and changes in the level of consciousness. Medical management can be utilized, and hypermagnesemia can be prevented by avoiding the administration of magnesium to patients with renal failure and by carefully monitoring seriously ill patients who are receiving magnesium salts. All parenteral and oral magnesium salts are discontinued. In emergencies such as respiratory depression or defective cardiac conduction, ventilatory support and IV calcium gluconate are indicated. Administration of loop diuretics and sodium chloride or lactated Ringer's IV solution enhances the magnesium excretion in patients with adequate renal function. In hypocalcemia, the serum calcium levels are less than 8.5 milligrams in a deciliter. Contributing factors are hypoparathyroidism, which may follow thyroid surgery or radical neck dissection, malabsorption, pancreatitis, alkalosis, vitamin D deficiency, generalized peritonitis, massive transfusion of citrated blood, chronic diarrhea, decreased parathyroid hormone, diuretic phase of renal failure, fistulas, burns, and alcoholism. Manifestations will include numbness, tingling of fingers, toes, and circummoral region, positive Trousseau sign, and the Trousseau sign is where the metacarpophalangeal joints are flexed and the inner phalangeal joints of the fingers and thumb are extended, and the thumb adopts a posture of opposition. Also, hyperactive deep tendon reflexes, irritability, bronchospasm, anxiety, impaired clotting time, decreased prothrombin, diarrhea, decreased blood pressure, and Chavosik's sign, which is to elicit that is begin by telling the patient to relax his facial muscles, then stand directly in front of him and tap the facial nerve either just anterior to the earlobe and below the zygomatic arch or between the zygomatic arch and the corner of his mouth. The positive response varies from twitching of the lip at the corner of the mouth to spasm of all facial muscles, depending on the severity of the hypocalcemia. Of hypokalemia will be seizures. They may occur because hypokalemia increases irritability of the central nervous system as well as the peripheral nerves. Other changes associated with hypocalcemia include mental changes such as depression, impaired memory, confusion, delirium, and hallucinations. Medical management is of the essence if it's an emergency. Acute symptomatic hypocalcemia is life-threatening and requires prompt treatment with IV administration of a calcium salt. Parenteral calcium salts include calcium gluconate and calcium chloride. Although calcium chloride produces a significantly higher ionized calcium level than calcium gluconate does, it is not used as often because it is more irritating and can cause sloughing of tissues if it infiltrates. In nursing, we must be aware and use seizure precautions, monitor airways. Nutritional therapy to tell the patient is vitamin D therapy. It may be instituted to increase calcium absorption from the GI tract. Otherwise, the amount of calcium absorbed may not satisfy the body's calcium requirement. Also, in watching for seizure precautions, we monitor airways because of laryngeal stridor can occur. Of course, safety precautions are taken. Also educate the patient about foods that are rich in calcium. The nurse must also advise the patient to consider calcium supplements if sufficient calcium is not consumed in the diet. Avoidance of alcohol and caffeine in high doses inhibit calcium absorption. And monitor cigarette smoking because that increases calcium excretion. The patient is also cautioned to avoid the overuse of laxatives and antacids that contain phosphorus because their use decreases calcium absorption. With the exemplar hypercalcemia, that is serum calcium greater than 10.5 milligrams per deciliter. Contributing factors are hyperparathyroidism, malignant neoplastic disease, prolonged immobilization, overuse of calcium supplements and vitamin D excess, oliguric phase of renal failure, acidosis, corticosteroid therapy, thiazide diuretic use, increased parathyroid hormone, and digoxin toxicity. Signs and symptoms include muscle weakness, constipation, anorexia, nausea and vomiting, abdominal pain, fluid volume deficit, polyuria and polydipsia, hypoactive deep tendon reflexes, deep bone pain, pathologic fractures, flank pain, calcium stones, hypertension, and ECG changes. Of hypercalcemia, we must treat the underlying cause. Example, chemotherapy for malignancy or partial parathyroidectomy for hyperparathyroidism. This is essential. For pharmacological, IV administration of 0.9% sodium chloride solution temporarily dilutes the serum calcium level and increases urinary calcium excretion by inhibiting tubular reabsorption of calcium. Administering IV phosphate can cause a reciprocal drop in serum calcium. Lasix is often used in conjunction with administration of a saline solution. In addition to causing diuresis, Lasix increases calcium excretion. Calcitonin can be used to lower the serum calcium levels and is particularly useful for patients with heart disease or renal failure who cannot tolerate large sodium loads. Calcitonin reduces bone reabsorption, increases the deposition of calcium and phosphorus in the bones, and increases urinary excretion of calcium and phosphorus. Nursing management. Interventions such as increasing patient mobility and encouraging fluids can help prevent hypercalcemia, or at least minimize its severity. Encourage oral fluids. Fluids containing sodium should be administered unless contraindicated, because sodium assists with calcium excretion. Patients are encouraged to drink 2.8 to 3.8 liters of fluid daily, which is really 3 to 4 quarts. Adequate fiber in the diet is encouraged to offset the tendency for constipation. And of course, safety precautions are implemented. Increased calcium increases the effects of digitalis. Therefore, the patient is assessed for signs and symptoms of digitalis toxicity if the patient is taking digitalis. Because of ECG changes, the cardiac rate and rhythm are monitored for any abnormalities. With the concept of clotting, the definition is a physiologic process in which blood is converted from a liquid to a semi-solid gel. We will be discussing the exemplars deep venous thrombosis and hemophilia.
Great. Okay. Venous thrombosis, we see this a lot at warm springs, post-surgery, impaired mobility, any kind of patient where they're not moving around, or there's a possibility there's post-surgery because there's a lot of blood loss or alterations in if they have issues with their bleeding, or if they're on aspirin. No, not aspirin, sorry. If they're on Lovenox helps it, I'm sorry. But if there's an issue where they're immobile, or if they've post-surgery, they're at high risk of developing a clot in their leg. And so a lot of times what happens, typically we want our blood flow to, with the ease, just kind of go through without any tension. But what happens is that there's either a clot that's lodged in the leg, and that it kind of impairs that regulation of gravity and blood pressure to kind of go straight through and ease its way through the vessel. What happens is we see, a lot of times we'll see edema, we'll see swelling of the extremity, redness, we'll feel warm, and we'll feel tenderness. A lot of times they'll complain of pain. So anytime you have a patient in the hospital and you're assessing their legs and their pulses, and you see, that their leg is significantly swollen compared to the other, and there's a big blotch of red, it's a DVT. So we need to act quickly, okay? Because there's a high risk of it going into the... Okay, some preventive measures for DVTs are, we're going to use the elastic compression hose. We use the SCDs. Those kind of compress and release. Post-surgical patients will do that. We'll use a heparin or warfarin to kind of aid in preventing them from clotting, making a clot. Also positioning. We're always going to elevate the extremities. We want to do active and passive limb exercises and deep breathing. We want to make sure we're encouraging early ambulation, specifically after surgery, because that kind of helps with the DVTs, and it also helps with pneumonia, okay? And we don't want them to be standing or sitting for long periods of time. So anytime like those issues occur, these are things that we want to teach these patients, so that it decreases their likelihood of a DVT. Because we don't want, the biggest thing is we don't want an embolism. Okay, so hemophilia is, it's a factor VIII deficiency. It's an X-linked recessive disorder. And what happens is that a lot of times with this, we have to do a lot of patient teaching, because it is something that we have to administer at home, factor VIII. And so a big thing, what we want to do is educate the families on injury prevention, because what happens is it makes them more susceptible to bleeding, okay? So anytime they're around, a lot of times with kids, we'll tell them to put helmets on, we'll tell them to put knee pads on to protect them from injury. For adults, we'll just educate them and tell them, like we won't ever tell them not to be doing contact sports, because that'll increase their likelihood of them getting injured. So we don't want that to happen. So we have to keep them very informed and aware that injury is something we don't want, because what happens is it can bleed in between the joints and can cause a lot of pain, okay? We want to tell them to avoid NSAIDs like aspirin, because that increases their bleeding. Dental hygiene is important because of their risk for bleeding. We don't want to have to use any kind of implants or anything like that, because it'll increase their susceptibility of bleeding. First aid, we want anytime any kind of small cut or opening, we're going to apply pressure for at least a minute to make sure that the patient stops bleeding, okay, because the likelihood of them bleeding is great, okay? So the treatment of choice is the recombinant factor VIII administration. We use this more than the fresh frozen plasma. So we'll do the recombinant factor first, factor VIII, okay?
The concept of teamwork and collaboration. The definition is the development of partnerships to achieve best possible outcomes that reflect the particular needs of the patient, family, or community, requiring an understanding of what others have to offer. We will be discussing conflict management strategies and operating room team as exemplars. With conflict management strategies, it's important to understand what is conflict. Conflict is generally defined as the internal or external discord that results from differences in ideas, values, or feelings between two or more people. Because managers have interpersonal relationships with people having a variety of different values, beliefs, backgrounds, and goals, conflict is an expected outcome. Conflict is also created when there are differences in economic and professional values, and when there is competition among professionals. Scarce resources, restructuring, and poorly defined role expectations are also frequent sources of conflict in organizations. Seeking consensus is a conflict management strategy. Consensus means that negotiating parties reach an agreement that all parties can support. Consensus decision-making does not provide complete satisfaction for everyone involved in the negotiation, as an initially unanimous decision would, but it does indicate willingness by all parties to accept the agreed-upon conditions. In committees or groups working on shared goals, consensus is often used to resolve conflicts that may occur within the group. To reach consensus often requires the use of an experienced facilitator, and having consensus-building skills is a requirement of good leadership. Perhaps the greatest challenge in using consensus as a conflict resolution strategy is like that collaboration. It is time-consuming. Within conflict management strategies, it's helpful to understand the conflicts. There is intrapersonal conflict, and that occurs within the person. It involves an internal struggle to clarify contradictory values or wants. For managers, intrapersonal conflict may result from the multiple areas of responsibility associated with the management role. Interpersonal conflict happens between two or more people with differing values, goals, and beliefs, and may be closely linked with bullying, incivility, and mobbing. There are helpful tips in conflict resolution. Focus on the causes of the disagreement and not on personalities. Try to arrive at solutions acceptable to everyone concerned. Get all the information possible and differentiate between facts and opinions. Listen carefully and do not prejudge. Do not belabor how the conflict occurred. Instead, concentrate on what should be done in keeping it from recurring. Concentrate on understanding and not on an agreement. Within teamwork and collaboration, an operating room team shows great collaboration. The collaboration is also evidence-based. The surgical team consists of the patient, the anesthesiologist, or the anesthetist, the surgeon, nurses, the surgical technicians, and the registered nurse first assistant, or certified surgical technologist. Nursing responsibilities include providing for the safety and well-being of the patient, coordinating the OR personnel, and performing scrub and circulating activities. Because the patient's emotional state remains a concern, the nursing staff provides the patient with information and reassurance, continuing the care initiated by the preoperative nurses, and the nurse supports coping strategies and reinforces the patient's ability to influence outcomes by encouraging active participation in the plan of care, incorporating cultural, ethnic, and religious considerations as appropriate. In discussing cultural diversity, cultural, ethnic, and religious diversity are important considerations for all healthcare professionals. Perioperative areas must be aware of any medications that may be prohibited by certain groups. Also, in certain cultures, the head is a sacred area, and the staff could follow their patients to apply their own surgical cap in this case. When English is the second language of a patient having surgery, certified medical translators can be provided to maintain understanding and comprehension by the patient. With the concept of perfusion, the definition is the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cell and removing cellular waste. The exemplars we'll be discussing are congestive heart failure, hypertension, mitral valve prolapse, coronary artery disease, and peripheral vascular disease.
So enough with the rhythms. We have heart failure. Okay, so we talked about, when we were talking about rhythms, we also talked about the heart being a big muscle. Okay, cardiac output is essential to meeting our metabolic demands. Well, heart failure is pretty much when that heart muscle cannot function adequately to produce these metabolic demands of the body. Okay, so usually that muscle gets tired and isn't pumping effectively. Okay, so in that case, we have an inability to perfuse our body and feed our tissues oxygen and nutrients. So a big thing with this, so if our muscle isn't effective and we're not meeting metabolic demands, our cardiac output has gone down, correct? And what happens is our body isn't recognizing that it's our heart that's not pumping right. Okay? So fluid is just staying there. Okay? Fluid is not making its way back to the heart, to the lungs, back to the body, all of that. That whole system is broken because the venous return is altered because that heart muscle isn't effective. Okay? So a lot of times what happens is that fluid stays in the body or in third spacing, which we talked about with fluid and electrolytes, and the body says, okay, well, we need to preserve more fluid, so it says, okay, let's get the kidneys involved. So it tells the kidneys to go ahead and activate the renin-angiotensin, which produces the aldosterone and the reabsorption of the sodium in the water. Okay? Now, see, the problem with that is that what happens if we're retaining sodium in water and our heart isn't pumping effectively, it's just going to make it even harder for that heart to work against all that pressure. But the body doesn't know that. Okay? So with all this, what happens is it eventually causes the heart a lot of stress and a lot of work. And so it ends up creating issues for the heart. It creates issues for the lungs because the lungs are having to work a little bit harder, and the return of blood, because the pumping action of the heart is altered, it can possibly regurgitate back up into the lungs from the right atrium. So, right ventricle, I'm sorry. So all of these things kind of play together. So when you do this, you're saying, okay, we have right-sided heart failure and left-sided heart failure. Okay, so if you look at right side, the right side of the heart pumps the blood to the lungs, correct? So if my right ventricle is failing, it's not going to make its way to the lungs. It's going to stop there. It's going to stop. It's going to make it harder. It's going to be sluggish. So it's going to go where? It's going to backflow. It'll backflow to the left ventricle, back up to the left atrium. Okay? So a lot of times what we're going to see is we're going to see systemic signs and symptoms. So if you see here, you'll see peripheral congestion, you'll see JVD, which is jugular vein distension. That's where we're close to the carotid artery right there, or the carotid artery. It's kind of, when you turn your neck, you can actually see that it's really tight in that area. You'll see edema, you'll see hepatomegaly, because all that blood flow is not making its way through the cycle. Okay, it's kind of just backed up. Okay, versus with the left side pretty much takes the blood to the body. If we have some kind of interference with that and it's not able to make its way through the left side, it's going to back up where? In the lungs. So we're going to see pulmonary alteration. So you're going to see shortness of breath, you're going to see congestion, you'll see difficulty breathing, all of those different signs and symptoms, because you're going to see pulmonary, because the blood's backing up to the opposite side. So what do we do for this? Well, we don't want to add more pressure to the heart because the pressure already is there, because the fluid's not making its way in and out of the body. So what do? We try to maintain the blood pressure and help relax those vessels to make it easier for the heart to work. Okay? So we do this by doing the ACE inhibitors, because we want to stop the angiotensin conversion enzyme, which is reabsorbing the sodium in the water. We can also use angiotensin receptor blockers, which are the same. They do the same effect. The Diovan would be an example. You can use beta blockers or hydralazine, and it's pretty much just to ease the workload of the heart. But the biggest thing with congestive heart failure, if you think about it, if a patient's heart is in right-sided failure, do we want to allow them to consume 3 liters of water? No, we don't. Because it's already backing up into the other side and creating systemic issues. So why would we encourage fluids? So a big thing with congestive heart failure is we want to limit the amount of fluids and make sure they're getting rid of any excessive fluids. So a lot of times these patients are on loop diuretics, the Lasix, and pretty much that kind of stops the sodium and the chloride to being absorbed. With diuretics, you want to make sure you're paying close attention to lab values, because you can see alterations in your potassium levels. You also want to make sure anytime you're administering loop diuretics, you assess their blood pressure, because the blood pressure, a lot of times they'll have hypotension. So we don't want to give them Lasix when they're already low on their blood pressure, because that's going to wipe them and bring them completely down. Okay? So we don't want to do that. And we also want to make sure that they're urinating as much as what we want. If we're giving them a diuretic, we by right need to see output coming off. If there's no output coming off, then we have a problem. So we need to look at that in terms of making sure whatever they're taking in, they're letting off, and that the Lasix is effective, because there is a lot of times we have to change our dosages of Lasix to meet the needs of the patient.
For nursing interventions of congestive heart failure, major goals for the patient may include promoting activity and reducing fatigue, relieving fluid overload symptoms, decreasing anxiety or increasing the patient's ability to manage anxiety, encouraging the patient to verbalize his or her ability to make decisions and influence outcomes, and educating the patient and family about the management of the therapeutic regimen. Managing fluid volume. The patient's fluid status is monitored closely by auscultating the lungs, monitoring daily body weight, and assisting the patient to adhere to a low sodium diet by reading food labels and avoiding high sodium foods such as canned, processed, and convenience foods. Weight gain in a patient with heart failure almost always reflects fluid retention. The patient is positioned or taught how to assume a position that also facilitates breathing. Controlling anxiety. Because patients with heart failure have difficulty maintaining adequate oxygenation, they are likely to develop dyspnea, which may in turn lead to restlessness and anxiety. Emotional stress also stimulates the sympathetic nervous system, causing vasoconstriction, elevated arterial pressure, and increased heart rate. This sympathetic response increases cardiac workload. Nurses' responsibilities are also to educate their patients. The nurse provides patient education and involves the patient and family in the therapeutic regimen to provide and promote understanding and adherence to the plan. When the patient recognizes that the diagnosis of heart failure can be successfully managed with lifestyle changes and medications, recurrences of acute heart failure lessen, unnecessary hospitalizations decrease, and life expectancy increases. To help you study, look at Chart 29.6, Home Care Checklist, the patient with heart failure. These things can include identifying heart failure as a chronic disease, take or administer medications daily, monitor effects of the medications, know signs and symptoms of orthostatic hypotension, have them weigh themselves daily with the same time and the same clothes on the same scale, watching the restricted sodium intake, participate in activity programs, develop methods to manage and prevent stress, making sure to keep regular appointments with the physician, being alert for symptoms that may indicate recurring heart failure, and report immediately to the primary provider following signs such as weight gain, shortness of breath, increased swelling, persistent cough, loss of appetite, development of restlessness, and profound fatigue.
Okay. The inverse of that is hypertension. So hypertension is opposite. Hypertension is when there's a lot of resistance in the blood vessels due to, sodium or water or even atherosclerosis that kind of makes it harder for that blood flow to go through the vessel. So ideally what we want is a blood pressure less than 140 and less than 90. But typically, anytime a patient has two consistent readings of 140 over 90, they're labeled hypertension. Okay, so here are our normal levels here, and actually, I just gave you pre-hypertension blood pressures, which is incorrect. Normal is 120 over 80, and pre-hypertension is 120 over 39. Okay, so if you look here, this is kind of just will tell you the measures that are used based on the treatment recommendations. So it's essential that, we kind of pay attention to that and see at what stage. For a pre-hypertensive patient, maybe a diet and exercise will help the patient. But at a point of stage 2, we're going to need medication. So that's what that is used for. So if you look at this kind of captures how high blood pressure kind of contributes to all these different changes that occur in our body. If you notice that there's a lot of contributing factors for high blood pressure, they're all listed in pink. We talked about excessive sodium intake. We didn't talk about stress, but stress can alter blood pressure. If you're nervous, that can go up your blood pressure. Remember, your parasympathetic and your sympathetic nervous system are triggered. So all those different things you want to see: obesity, hypertension, not hypertension, hyperlipidemia, glucose. If there's a patient with diabetes, they're likely to have high blood pressure. And so if they have both, it's a double whammy because it's going to make it even harder for that blood to go through that vessel. So some of the manifestations of hypertension, that just think about it, if it's affecting vessels, a lot of times they're going to have alterations in their small vessels and large vessels. So you'll see changes in their eyes. You'll see a lot of times the major vessels in the heart are compromised and they aren't able to get their oxygenation that they need, and that can lead to an MI or stroke. So all those different things, this is why we want to make sure that we are very aggressive with hypertension, because we want to avoid these things. So some of the major risk factors we're looking at, we want to make sure that we acknowledge, because a lot of times this can kind of gear us to what kind of health promotion teaching we provide. Major hypertension, that was a typo. Smoking will work against. Smoking is a vasoconstrictor, okay? So if we're already having difficulty making its way through the blood vessel, if we're smoking, we're making that blood vessel even smaller, okay? So it's working against it. If they're obese, you know that the heart is already being strained. If you're overweight, you're working a little bit harder, so it's going to require more strain on the heart. So those are big issues. Physical inactivity, if they're bedbound or things like that, or they're just not wanting to exercise, that can contribute to high blood pressure. A large amount of consumption with fatty foods is another indication, another red flag for hypertension. Diabetes, alterations in their glomerular filtration rate, which means a lot of times with our patients that are in renal failure, they automatically, their kidneys shut off, and so guess what? We have no way of getting rid of our excessive volume, so it stays in the body. So it just creates another issue for our heart. So that's another problem. And as we get older, our muscles, tend to not work as well. The heart has been working for many years, so a lot of times it's not that the muscle stretches, or if there's changes to the body, it can make it a little bit more difficult. And then family history, of course, a lot of times patients with any kind of genetic predisposition, like African Americans, are high risk for high blood pressure. It's in their history. So it's more predominant in African Americans. So a lot of times we're automatically, our disposition is greater because of our family history, our genetics. So it's inevitable that it's in us. So what are we going to do for these patients? We're going to encourage them to be proactive. We're going to have them monitor their blood pressure daily. We're going to keep them on a weight management program, encourage exercise. We're going to limit the amount of salt they take, because the salt is going to make it difficult for those vessels to make its way and to get perfused. And we want to make sure that they're not encouraging any alcohol consumption, okay? As far as treatments, we're going to be looking at blood pressure medications to kind of help regulate regulate the tension in the vessels. And also, we're looking at diuretics to remove any excess fluid. So a lot of times in combination therapy, they'll use these. What we usually see with the mitral valve prolapse is that what happens is that valve is not functioning correctly, and so it promotes blood to go from the left ventricle back up in the left atrium. Okay, and so it kind of makes it more difficult. It doesn't keep it enclosed, if that makes sense. So typically what we see are some of the signs and symptoms are fatigue, shortness of breath, lightheadedness, dizziness, syncope, palpitations, chest pain, and anxiety. The important thing what you want to know is that somebody that has a mitral valve insufficiency, you won't see these symptoms all the time. So that's important method. That's an important instruction for you to include with your patients, because a lot of times, if there's an indication that their mitral valve has, if there's a compromise at all in the patient, then you'll see these changes. If it's exacerbated or it's gotten worse. Correction. Sorry. So a big thing what we want to teach our patients is that because they have that regurgitation of blood flow back into the left ventricle, we're going to want to make sure that they know that they're at risk for ineffective endocarditis, which we don't treat anymore with prophylactic antibiotics. So we just want to make sure that they're educated, that they know that they're at a greater risk for infective endocarditis. Symptoms awareness, especially symptoms awareness is important because if they've had a valve replacement, then we want to make sure that they know that if there's something going on, then they'll have those same symptoms if there's a failure. We want to encourage them to avoid alcohol and caffeine because it stimulates the heart, and it'll make it harder for the heart, it'll increase the workload of the heart even greater. We want to make sure that we're also reading over any over-the-counter medications, because a lot of medications like have ephedra, they'll have caffeine or pseudoephedrine, and it strains the heart muscle. So we don't want to put any effort on the heart muscle than we have to. So it's recommended that we consult a physician when we're taking over-the-counter medication. We want to make sure that we're checking those lifestyle factors that may correlate with the symptoms, because it may not be a true indication that it's a prolapse, because what happens is a lot of times it's women that they don't sleep enough, or they have decreased activity and they might feel fatigue. It may not be attributed to the mitral valve. Mitral valve is a genetic predisposed condition, and so a lot of times when we go to the doctor and we say, okay, I'm feeling this, I'm feeling that, they automatically will think it's the mitral valve, but you have to look at everything, if that makes sense.
Perfusion, there is the exemplar coronary artery disease. Coronary artery disease is the most prevalent type of cardiovascular disease in adults. The most common cause of cardiovascular disease in the United States is atherosclerosis, an abnormal accumulation of lipid or fatty substances and fibrous tissue in the lining of arterial blood vessel walls. These substances block and narrow the coronary vessels in a way that reduces blood flow to the myocardium. The inflammatory response involved with the development of atherosclerosis begins with injury to the vascular endothelium and progresses over many years. The injury may be initiated by smoking, hypertension, hyperlipidemia, and other factors. The endothelium undergoes changes and stops producing the normal antithrombotic and vasodilating agents. The presence of inflammation attracts inflammatory cells, such as monocytes, which are macrophages. The macrophages ingest lipids, becoming foam cells that transport the lipids into the arterial wall. Some of the lipid is deposited on the arterial wall, forming fatty streaks. A thrombus may then obstruct blood flow, leading to acute coronary syndrome, which may result in an acute myocardial infarction. When a myocardial infarction occurs, a portion of the heart muscle no longer receives blood flow and becomes necrotic. Coronary artery disease produces symptoms and complications according to the location and degree of narrowing of the arterial lumen, thrombus formation, and obstruction of blood flow to the myocardium. This impediment to blood flow is usually progressive, causing an inadequate blood supply that deprives the cardiac muscle cells of oxygen needed for their survival. The condition is known as ischemia. Angina pectoris refers to chest pain that is brought about by myocardial ischemia. Angina pectoris usually is caused by significant coronary atherosclerosis. Coronary artery disease have risk factors. There are non-modifiable risk factors, which is a circumstance over which a person has no control. A modifiable risk factor is one over which a person may exercise control, such as by changing a lifestyle or personal habit, or by using medication. So some of the modifiable risk factors are hyperlipidemia, cigarette smoking or tobacco use, hypertension, diabetes, metabolic syndrome, obesity, and physical inactivity. Non-modifiable risk factors include family history of coronary artery disease, increasing age, which is more than 45 years old for men and more than 55 years old for women, gender, men seem to develop coronary artery disease at an earlier age than women, and race, higher incidence of heart disease in African Americans than in Caucasians. Because of this, there are prevention opportunities for the 4 modifiable risk factors of the cholesterol, tobacco, hypertension, and diabetes. In controlling cholesterol abnormalities, there is an association of a high blood cholesterol level with heart disease. It is well established, and the metabolism of fats is known to be an important contributor to the development of heart disease. Fats, which are insoluble in water, are encased in water-soluble lipoproteins that allow them to be transported within the circulatory system. When an excess of low-density lipoproteins is produced, low-density lipoprotein particles adhere to receptors in the arterial endothelium. Here, macrophages ingest them, contributing to plaque formation. What there is a positive are high-density lipoprotein levels. A person with a high-density lipoprotein level is a strong negative risk factor for heart disease, meaning it protects against heart disease. Other factors are dietary measures. A diet low in saturated fat and high in soluble fiber, or a diet that promotes vegetables and fish and restricts red meat, is also reported to reduce mortality from cardiovascular disease. Smoking cessation, of course, is a modifiable risk factor that can be controlled by the patient. A person at increased risk for heart disease is encouraged to stop tobacco use through any means possible. Educational programs, counseling, consistent motivation and reinforcement messages, support groups, and medications. Some people have found complementary therapies like acupuncture, guided imagery, and hypnosis to be helpful. People who stop smoking reduce the risk of heart disease within the first year, and the risk continues to decline as long as they refrain from smoking. In coronary artery disease, angina is usually caused by atherosclerotic disease. Almost invariably, angina is associated with a significant obstruction of at least one major coronary artery. Normally, the myocardium extracts a large amount of oxygen from the coronary circulation to meet its continuous demands. When demand increases, flow through the coronary arteries needs to be increased. When there is a blockage in a coronary artery, flow cannot be increased and ischemia results. There are several factors associated with typical anginal pain. There's physical exertion, which precipitates an attack by increasing myocardial oxygen demand. There is also exposure to cold, which causes vasoconstriction and elevated blood pressure with increased oxygen demand. Also, eating a heavy meal that increases the blood flow to the mesenteric area for digestion, thereby reducing the blood supply available to the heart muscle. In a severely compromised heart, shunting of blood for digestion can be sufficient to induce anginal pain. And fourth, stress or any emotion-provoking situation, causing the release of catecholamines, which increases blood pressure, heart rate, and myocardial workload. A person with angina pectoris has a feeling of weakness or numbness in the arms, wrists, and hands, as well as shortness of breath, pallor, diaphoresis, dizziness, or lightheadedness, and nausea and vomiting. An important characteristic of angina is that it subsides with rest or administering nitroglycerin. Medical management of angina are to decrease the oxygen demand of the myocardium and to increase the oxygen supply. Nitrates, or nitroglycerin, are a standard of treatment for angina pectoris. Nitroglycerin is a potent vasodilator that improves blood flow to the heart muscle and relieves pain. Nitroglycerin dilates primarily the veins and, to a lesser extent, the arteries. In self-administering nitroglycerin, the nurse must discuss potential side effects of nitroglycerin, which include flushing, throbbing headache, hypotension, and tachycardia. When a nurse comes into the ER or on the floor and a patient complains of angina, they must treat immediately. The patient experiencing angina is directed to stop all activities and sit or rest in bed in a semi-phalange position to reduce the oxygen requirements of the ischemic myocardium. In the hospital, a 12-lead ECG is usually obtained and assessed for ST segment and T wave changes. If a patient has been placed on cardiac monitoring with continuous ST segment monitoring, the ST segment is assessed for changes. We also must give the nitroglycerin. It's administered sublingually and the patient's response is assessed. The response hopefully would be relief of chest pain, and it would affect the blood pressure and heart rate. If the chest pain is unchanged or is lessened but still present, nitroglycerin administration is repeated up to 3 doses. Oxygen is usually administered at 2 liters by nasal cannula, even without evidence of desaturation, although there is no current evidence of a positive effect on patient outcome. If the pain is significant and continues after these interventions, the patient is further evaluated for acute myocardial infarction and may be transferred to a higher acuity nursing unit.
To begin, peripheral artery disease is pretty much related to the narrowing of the vessel due to fat or plaque that kind of builds up and calcifies around the vessel. So primarily, peripheral artery disease contributes mainly to a lot of times to alterations in blood flow to major arteries. Typically, peripheral artery disease is usually related to atherosclerosis, which is the thickening of the walls with the fat. But in some cases, we can see peripheral artery disease with patients that have diabetes. And we'll go further along with that. But usually it's because of their insulin insufficiency that they are, their blood is a little bit thicker and it's a little bit harder to perfuse through the vessels. All the vessels in the body, if you look at all the arteries that are listed, these are all major arteries in the body. So typically when these are obstructed due to peripheral artery disease, then we're looking at a major compromise of perfusion. So this is just kind of a diagram of where you can review the locations of the arteries. High risk factors for peripheral artery disease are usually any patients between the ages of 60 to 80. If you think about what atherosclerosis is, you want to think about patients that are obese, that they have a BMI greater than, I think it's greater than 20, and they have a history of smoking, because when they smoke, it kind of thickens that plaque and it makes it harder to get rid of in the vessels. If they've been consuming large amounts of fat, if they have high blood pressure, because if you think of diabetes, there's a lack of insulin, which makes the blood viscosity a little bit thicker. Hypertension is pretty much pressure in the vessels made by fluid, an excessive amount of fluid. So the venous return of the blood flow is altered. So if there's an extensive amount of pressure and it's inhibiting that blood flow through the vessels, it's going to make it a little bit difficult for those vessels to get fed. Okay, so these are the biggest risk factors for patients for peripheral artery disease. Biggest thing that we look at when we're assessing patients for peripheral artery disease is the intermittent claudication. And that is usually where they get it feels almost like a Charlie horse. It's usually dependent upon pretty much it's like a time where there's a lack of perfusion or a lack of oxygenation to that area that usually is related to exercise. So it'll usually take a while for it to go away, but if you have If you rest for a little while, it usually will alleviate. But it's like this horrific pain that a lot of times patients complain about, and it doesn't subside till after a few minutes or so. Paraskinesia is pretty much the numbness and tingling of the feet. This usually we see with diabetics, if you notice, and this is why we do foot care with them. It's just due to the altered blood perfusion to the extremities. You'll have a sensation that it feels like your feet are asleep, and there's little pricklies on your feet. So a lot of times we see this, or the patients feel this. This is a big thing and a big issue as far as injuries, because when we have patients with diabetes or high blood pressure, they're likely to get gangrenous ulcers on their feet because of the altered perfusion in their vessels of their lower extremities. Another thing that you'll notice when you're looking at patients with peripheral artery disease is that a lot of times, if you think about grass, where there's a lot of where there's a lot of water, grass will grow. So if you think of the same situation as far as perfusion, if there's not a lot of perfusion to that area, you're going to see no hair. Okay? So patients usually with peripheral artery disease really have tight skin, tight shiny skin, and they don't have that much hair. Hair usually, follicles need that perfusion to grow. And so if they're not meeting that, then you're not going to see hair growth in that area. So that's why we look at normal distribution of hair, because that can indicate if there's an altered perfusion in the body. Okay? And of course the pulses will indicate if there's circulation occurring. Color, coolness or warmth to the extremities, we want to assess for these things, because those can indicate whether or not that there's circulation occurring. And also just making sure that there's no pain when they're altering in a different position. Okay. Another thing which we see is the pain at rest, and usually that occurs in the toes, and it's aggravated by limb elevation, and it primarily occurs at night, but the biggest thing is it's insufficient blood flow. And so we really want to make sure that that's something that we assess for, because it can create issues for the patient and it can compromise the perfusion. So biggest thing when you're looking at perfusion, particularly with peripheral artery disease, is that you're wanting to see and make sure that there is circulation going in that area, because impaired circulation leads to impaired wound healing. It's not getting the blood and the nutrients needed to heal and to grow, and all of that is necessary for our bodies. So anytime that we're looking at this, we want to make sure that we're assessing for, and we're ruling out and making sure that these patients do have good perfusion, because in the event that they don't, then we could possibly look at a patient that losing a limb, or possibly a gangrenous area or necrosis. So we just want to make sure that we're meeting that objective. Okay, so some of the things that we can teach our patients are: stop smoking immediately, try to use nicotine as needed. We want to make sure that they're taking their cholesterol medications, their Lipitor. They're not stopping and then starting, because they can get rebound hyperlipidemia when they do that. They maintain their blood pressure and their hemoglobin A1C levels. The blood pressure needs to be less than 140 to 90, because we want to make it easy for those vessels to get perfused. If the blood pressure is elevated, it increases the resistance, so it makes it harder for those vessels to get that blood flow. The A1C, we want to make sure that it's less than 7, which means that it's the life of the red blood cell. Usually if a patient continuously has high blood sugars, their A1C will be up, because there's a lifespan of the red blood cell that actually decreases with elevated blood sugars. And so we want to make sure that their A1C and their blood sugars consistently stay within normal limits, because this will indicate whether or not their perfusion is what it should be. So these are just some examples of medications and treatments. There are some treatments that we do to help with PAD peripheral artery disease. We do antiplatelet therapy because we want to make sure that there's no stasis of the blood, because then we're looking at clots. Statins help enhance the perfusion, and the Trental and the Pletal help with the intermittent claudication. And that's the one where when exercise or exertion, the pain starts occurring, okay, and then we have to rest. A lot of times what we have to look at is surgery, which is the bypassing of the grafts, and that comes later. Usually if all those treatment modifications aren't working, lifestyle modifications, we have to look at possibly replacing that vessel in the leg or so, just to enhance the blood flow. So post-op nursing manage, if they get a graft, is that we want to make sure that we're monitoring their output, monitoring their intake and output, and also their CVP, which is linked to fluid volume status. So we want to make sure that they're adequately hydrated, there are no changes in mental status, their pulse rate's normal, and there's no changes in their electrolytes. We want to check for bleeding because they are on anticoagulants. We want to have them prevent leg crossing and any kind of dependency on the extremity, because what happens is it could possibly interfere with the blood flow. Elevation of the extremities enhances the blood perfusion and the venous return. Also, the compression stockings will help compress and pull out that edema that's in the lower extremities. We want to make sure we're maintaining circulation, assessing for pulses, color, temperature, and capillary refill. All these indicate perfusion. So if we're not feeling pulses, if you're feeling +1 pulses, that means that there's no circulation, or there's hardly any circulation going there. So a lot of times, anytime we suspect that there's an alteration in perfusion, as far as is through the extremities, we want to double check and use a Doppler, especially if we can't feel it, if it's not palpable. A lot of times, if it's for a diabetic, it is very hard to feel pulses, so we have to use a Doppler. Okay, health promotion, what we want to do is we want to make sure that they're doing at least 30 to 60 minutes a day. And the biggest thing is patients that have intermittent claudication, the best remedy is to walk. Walking really helps alleviate that. Nutrition, we want to make sure that their BMI is less than 25. Waist circumference, big thing, cholesterol, sodium, salt intake, because that's linked with our high blood pressure, and fat intake, which is linked to the atherosclerosis. So we want to make sure that we prevent any kind of buildup, and also we want to promote smoking and tobacco cessation, because that works against what we're doing.
The concept leadership and management definition is: management is the process of coordination and integration of resources through planning, organizing, coordinating, directing, and controlling to accomplish specific institutional goals and objectives. Leadership is the process of influencing people to accomplish goals. The exemplar for discussion is delegation. Within the concept leadership and management, the exemplar delegation has long been a function of registered nursing. Delegation can be defined simply as getting work done through others, or as directing the performance of one or more people to accomplish organizational goals. Even more complex definitions of delegation, supervision, and assignment have been created by the American Nurses Association and the National Council of State Boards of Nursing in response to the emerging complexity of delegation in today's healthcare arena, where increasing numbers of unlicensed and relatively untrained workers provide direct patient care. Identifying necessary skills and educational levels is necessary to complete this job of delegation. Often legal and licensing statutes, such as the Nursing Practice Act, determine this. Professional nurses work with a variety of different types of caregivers, but the scope of practice for the RN is typically defined by the Board of Nursing in each state. The challenge is that the RN must also understand the scope of practice of others on the nursing team who are providing patient care. Nurses then must be aware of their state Nursing Practice Act essential elements regarding delegation to include the following: the state's Nursing Practice Act definition of delegation, items that cannot be delegated, items that cannot be routinely delegated, guidelines for RNs about tasks that can be delegated, a description of professional nursing practice, a description of LVN and licensed professional nurse LPN nursing practice and unlicensed nursing roles, the degree of supervision required to complete a task, the guidelines for lowering delegation risks, warnings about inappropriate delegation, and if there is a restricted use on the word nurse to licensed staff. In addition, the manager should know the official job description expectations for each worker classification in the organization, as they may be more restrictive than the State Nursing Practice Act. Monitoring delegated tasks is effective delegation. Setting timelines and monitoring how the task is being accomplished through informal but regularly scheduled meetings. This shows an interest on the part of the nurse leader, provides for a periodic review of progress, and encourages ongoing communication to clarify any questions or misconceptions. The RN must monitor and evaluate both the patient and the staff's performance of delegated tasks and be prepared to intervene on behalf of the patient as necessary. In doing so, the leader manager provides staff feedback to increase competency in task performance. This keeps the delegated task before the subordinate and the manager so that both share accountability for its completion. Although the final responsibility belongs to the delegator, the subordinate doing the task accepts responsibility for completing it appropriately and is accountable to the person who delegated the task. Delegating decision-making without providing adequate information is an example of improper delegation. Delegation errors could be avoided if the 5 rights of delegation identified by the American Nurses Association and the National Council of State Boards of Nursing were followed. These 5 rights of delegation include the right task, one that is delegable for a specific patient, a right circumstance, appropriate patient setting, available resources, and other relevant factors considered, the right person. The right person is delegating the right task to the right person to be performed on the right person. Right direction and communication. Clear, concise description of the task, including its objective, limits, and expectations. And last, the right supervision. Appropriate monitoring, evaluation, intervention is needed, and feedback.